I'm going to turn over the introduction of our visiting professor today, who also has a long tradition of being involved in the life of academic medical centers, to our vascular chief, Matt Mouth.
Thank you. It's really my distinct honor and pleasure to welcome Fred Weaver as my first invitee visiting professor since in my tenure here at UC Davis. Many of you may have crossed paths or know Dr. Weaver. Dr. Weaver is the division chief for vascular surgery at USC. He actually hails from Southern California, did his college and medical school at USC, went to Vanderbilt for his general and vascular training, came back to USC, and he's been there ever since. He has been the president of the Western Vascular Society. He was president of Pacific Coast Surgical. He was president of Society of Clinical Vascular Surgery. I actually think that Pacific Coast and Society of Clinical Vascular Surgery were at the same time, as I recall. They were concurrent. So that was a handful, I'm sure. In 2015, he received the Society for Vascular Surgery Presidential Citation Award. He's an associate editor for Journal of Vascular Surgery. He's on the editorial board for Annals of Vascular Surgery, and he currently serves as the chair for the SVS Patient Safety Organization, which is the organization that oversees VQI, which is our national vascular quality initiative. He has published over 200 papers, 43 textbook chapters, and has had a very, very successful multidisciplinary aortic program, and he's going to share that experience with us today. And so it's really my pleasure to introduce Dr. Weaver.
Well, thank you, Matt, so much. It's just a real pleasure to be here, and particularly to give a lectureship in memory of a resident from UC Davis. Let's see. I'm gonna advance that. There we go. So this is where I hail from. This is the old county hospital, which many of you have probably seen in General Hospital, the soap series that actually is still going on, I think, from what I understand. The new hospital, which opened about, I'd say, a decade ago, is just in front of that. And then Keck Medical Center is this footprint here, which has been in existence for 30 years, but over the last decade has really begun to blossom. So greetings from the Division of Vascular Surgery and Endovascular Therapy. So I asked for a little information about Dr. Reinsch, and this is something from his surgical application that I thought was particularly pertinent, and specifically for surgeons, very insightful. My decision to specialize in surgery is based on two factors: my somewhat mechanical worldview, or action in doing or foremost. I think most of us can relate to that. And the observation that it was the surgeon who cared most about the patients, and if the patient was to be helped, it was the surgeon who most often did so. I thought those are very, very insightful comments, and that was actually on his personal statement when he was applying for surgical residency. And then he finished that with, "I doubt if I would be happy in any other field of medicine." So this was a true surgeon. It's a great legacy for him. Also want to recognize the department leadership here, because that's one reason that Dr. Reinsch felt the way that he did. Dr. Bill Blaisdell, who needs no introduction. But when I was a medical student, Dr. Blaisdell took over this department. And we all heard great things about him down in USC, and I actually had some medical students that migrated up here because of his brilliant surgical leadership. And then Jim Goodnight, who I've got to know very, very well through Pacific Coast Surgical, Jim, I tried to get a little bit better picture on the internet of you, and this is about it. So I think you need to add something at some point. And then the current leadership, Dr. Diana Farmer, who has taken this department to new levels, and just like the number of people in this room, you go to a lot of surgical grand rounds, and there's about 3 people for surgical grand rounds, and I can tell you that our department would be jealous looking at the turnout that's here. That's a real testimony to her leadership. And then Dr. Matt Mell, I'm so happy that Matt is here. He will do great things for vascular surgery at UC Davis. So we're going to talk a little bit about aortic disease and aortic aneurysms and the evolution of treatment. Osler put it well. There is no disease more conducive to clinical humility than the aneurysm of the aorta. And, you know, he spoke this at the turn of the last century when it was basically an inoperable lesion that patients died from because there was absolutely no therapy available. We've come a long, long ways since that time. When I finished in 1986 at Vanderbilt, we had an operating room. We had these nice Dacron grafts, and we sewed the grafts in. It was a great operation. It was really a lot of fun. Patients did pretty well. This is the way it looked intraoperatively. In case, for those of you who have never seen an intraoperative aortic graft, this is what they look like. But in 1999, actually in the 1990s, everything changed, and I'll go through that. A disruptive change in the way that vascular disease was treated. And we went to hybrid OR suites. This is a 1999 first generation hybrid OR suite at Keck, putting in Ancure grafts, which were taken off the market shortly after they were placed by the FDA and by the company. But this is the kinds of pictures that we had. This is a finished product. It was seen on a angiographic image. And actually, when you look at how dismal the prognosis was for aortic aneurysm disease 100 years ago, there's been a lot of progress. Both open and endovascular repair, there's about a 40% 12-year survival, which is really quite laudatory, particularly when you consider that this was not always the case. This is a classic paper by Earl Estes, looking at the natural history of aortic aneurysms not repaired. And as you can see, the survival rate at 8 years was 10% in his series. And this was prior to really the routine repair of aortic aneurysms. So the concept of aneurysma, from the Greek, a widening, is written about all the way back to the 1500s BC. Most of these were peripheral aneurysms. In fact, all of them were peripheral aneurysms, ones that could easily be seen. Most of the treatment for centuries was basically ligation, obliteration. Not much else could be done. The concept of replacing the aneurysm with some kind of arterial substitute was not even considered. Ashley Cooper, Cooper ligament fame. This was an incredible surgeon in England in the 1800s. He was a superb anatomist. He actually paid grave robbers to get bodies from the cemetery so he could do dissections and become familiar with the anatomy. So he understood the abdominal aortic anatomy really quite well. And so in 1817, there was a 38-year-old porter who had a large eroding external iliac artery aneurysm. Most of the aneurysms at this time were syphilitic in origin. And Dr. Cooper, and it would only be Dr. Cooper, who would then decide to take the patient to the operating room and actually treat this patient by making an abdominal incision. Think about that. There was no general anesthesia. There was no antisepsis. Think about what a bold surgical feat this was. And then he describes it just beautifully, having made a sufficient opening to admit my finger, I pass between the intestines to the spine, and every surgeon that has ever operated on the aorta knows this move where you put your finger behind the aorta, between the aorta and the spine. He describes it beautifully. And once he had his finger around the aorta and between the spine, he then put a big ligature and just ligated the distal abdominal aorta to treat this aneurysm. Patient ultimately died 48 hours later. But this was a surgical feat that nobody else really, people did attempt, but didn't really get close to even getting the patient off the operating room table. And why was that? Well, as I mentioned, there was no anesthesia. That we had to wait till 1846 for that. The germ theory, the fact that bacteria, infections, and the like had not been recognized until 1860. And then Lister with antisepsis in 1865. These were all necessary things to actually allow the direct attack on the abdominal aorta and aneurysms. But still, it's very formidable, and nobody would attempt to do that given the current technology. Now, Rudolf Matas, and we'll get to him in just a little bit more about his role with aortic aneurysms, but he actually, in talking about the treatment of peripheral aneurysms, came up with the concept of endoaneurysmorphy, i.e. fixing the aneurysm from inside. Not just not ligating it, which is what was the kind of the standard at the time, but actually oversewing the lumen such that you would maintain flow within the open aneurysm and preserve flow in the extremity. And this was a big advance in the concepts of how to deal with aneurysm disease. But even at that time, in his personal memoirs, he talks about the fact that for a direct attack on an aortic aneurysm, it was in essence inoperable. So there was coiling, there was banding, there was wrapping, there was all kinds of things that you would do to try to restrain the growth and contain rupture, but no direct attack was really feasible. He did, however, in 1925, in a woman, another syphilitic aneurysm, large aortic syphilitic aneurysm. He had the necessary anesthesia, antisepsis, and instrumentation that he felt comfortable enough to take the patient to the operating room, do a midline incision, and actually ligated the abdominal aorta. She actually survived for about 14 months and died of a pulmonary hemorrhage due to tuberculosis subsequently. But this was a major advance in the treatment of abdominal aortic aneurysms, actually attacking directly the abdominal, attacking the aorta directly. This is a little vignette. It's kind of an interesting story. These two gentlemen met in Brooklyn Jewish Hospital in the operating room. Nissen, of course, is well known for the Nissen fundoplication. He was a Jew that left Hitler's Germany in 1933 and ended up at a Jewish hospital in Brooklyn. Albert Einstein, who needs no introduction, he was the person of the century. He also left Hitler's Germany in 1933 and ended up at Brooklyn Jewish with abdominal pain. So Nissen took Albert Einstein to the operating room for an exploration of intestinal cysts. Actually, what he found was, abdominal aortic aneurysm, which he subsequently then wrapped with cellophane, which was the standard therapy for aneurysm disease at that time. And I'll get back to Albert Einstein in a little bit. The idea of actually replacing the aorta, that aneurysmal component, really started with Alexis Carrel and his concept of using arterial and venous substitutes to replace or transplant vessels. The Carrel technique, which you're all familiar with, he popularized and created. He got the Nobel Prize for his work. Most of his work was really geared towards transplantation, but important aspects of his work was the concept that you could replace arterial segments with other arterial segments. And this is just from some of his work, the triangulation method of suturing that he developed. It took a while, but his concept of vessel transplant and direct anastomosis of arteries finally was consummated with Gross, who did a coarctation repair. This is a simple anastomosis in 1948. Again, if you just think about 1948, that's a pretty incredible feat. And then that emboldened others, along with Carell's thoughts of replacement, to use various substitutes to replace the aortic aneurysm. Actually, Freeman and Leeds were from San Francisco, and they did actually 3 replacements of abdominal aortic aneurysms, the first being the first in 1951 prior to DeBost, who actually did one with a homograft in France. And there was Schaefer and Harden, who also did a homograft, but neither of those patients survived. But DeBost in 1951, March, successfully repaired and replaced the abdominal aorta with a homograft. Now these homographs, this is a picture of one here. Actually, we have this in our hallway in our vascular group. It's Max Gaspars, who was a very important surgeon, vascular surgeon at USC. This is one of his homographs that he used, created in the 1950s to replace the abdominal aorta, and it's in a vacuum tube, and it's preserved. It's a pretty neat artifact from a time that's long past. The other major breakthrough that then happened was the idea, well, okay, so we can use some kind of biologic tissue, but what about, can we create an artificial graft? And Voorhees at Columbia University with Dr. Blakemore began to experiment using a material called Vignon, which is basically a cloth, making tubes out of it and basically replacing aortas in dogs, and reported outstanding results. And actually an opportunity occurred where a patient came in with a ruptured aneurysm. They did not have any homographs available. So Dr. Blakemore said, well, why don't we just put one of those Vignon grafts in? Let's see how that works. And so they actually replaced an abdominal aortic aneurysm with a prosthetic graft, something that would never happen in today's IRB regulatory state. Michael DeBakey was very, very fascinated by this concept, and so he said he went to a department store and he asked for some Vignon so he can make these tubes and start doing his own experiments. They said, we don't have any Vignon, we're out of Vignon, but we do have this new material called Dacron, and it's pretty nice, maybe you want to try it. So he bought a bunch of Dacron, went home. His mother actually was a seamstress and had taught him how to sew. So he sewed tubes and started to put these tubes in dogs and had terrific results. And that's why we now have a Dacron graft that was created by Dr. DeBakey back in 1955. And that became the standard replacement for an abdominal aortic aneurysm. And if you remember Matas's endoaneurysmorphy, Dr. Creech, who was a resident of Dr. Matas, combined the replacement of the aorta with a Dacron graft with the endoaneurysmorphy concept of just simply opening the aneurysm, replacing it, and leaving the aneurysm, not resecting and removing the entire aneurysm. And this was a standard of care when I finished my residency in 1986. And Dr. Zizlagli demonstrated that there was a significant improvement in survival by approaching and replacing the abdominal aorta with a Dacron graft. This is a comparison of surgical and non-surgical patients. And if you look across at an 8-year period, 30% survival in the patients that underwent surgical repair, and only 6% survival in those who did not. And this pretty well established the effectiveness of this surgical therapy. So just to change gears a little bit, which is interesting how two kind of constructs in time that are completely separate then become combined. There was a radiologist named Charles Dotter, and the surgeons called him Crazy Charlie, because he was a man well ahead of his time. This is a great quote. The angiographic catheter can be more than a tool for passive means for diagnostic observation. Used with an imagination, it can become an important surgical instrument. Just think about that in the way that we treat vascular disease now. He said this in the 1960s. So, Dotter created the concept of endoluminal treatment for vascular disease. He actually had these stylets and would daughter. If you work with any of the vascular surgeons, they say, well, we daughtered that. That's basically just a gradual intraluminal dilatation by an instrument. And so Dr. Dotter at the University of Oregon began to pioneer this concept. The surgeons up there really didn't like it because he seemed to be honing in on their territory, and he thought that he was crazy. So they would make very specific requests. You know, visualize, but do not fix. Okay? But it's interesting, Dotter had one patient that he had an SFA stenosis, and there was a profunda stenosis. And so he knew the surgeon was going to fix the SFA, so he went ahead and daughtered the profunda stenosis. The surgeon then did the fem-pop bypass. The fem-pop bypass failed, but the daughtered profunda femoris stayed open and actually is what salvaged the patient's leg. And he loved to tell this anecdote, particularly to surgical audiences. Andreas Grunzik, and you may have heard his name, he's the father of coronary angioplasty. He came from Germany and ended up landing at Emory and unfortunately died in an airplane crash at a much too early stage of his career. But he developed the concept of inflating a balloon inside an artery to deal with a stenosis. But he also recognized that there was a tremendous amount of recoil and that the longevity and the durability of these dilatations was short-lived. So Julio Pomaz, in talking with Grunzik, thought about the concept of a scaffold, a stent, if you will, which would be loaded onto a balloon. So the balloon angioplasty is Grunzik's concept, and then you load the stent onto the balloon, and then you deploy the stent with the dilatation of the balloon. Dr. Pomaz did very well with this, and he sold it to J&J for $100 million. He's got a very nice vineyard pretty close to here, and makes pretty good wine. So Juan Perotti, who was a resident at the Cleveland Clinic, but actually from Argentina, as was Julio Pomaz, they befriended each other and talked about these concepts. And Dr. Perotti was particularly chagrined with the difficulty, pain, and discomfort that patients went through when they had an abdominal aortic aneurysm repair. He said there's got to be a better way to do this. And so he came up with the concept of taking a graft that was created by DeBakey and others in the 50s, taking the balloon and stent that Grunzik and Pomaz had advanced, and putting these all together to create an endoluminal repair for abdominal aortic aneurysms. A completely disruptive change in the way that surgeons would approach a disease. So some of these quotes are kind of apropos to Dr. Perotti because at the time he was not beloved by the vascular surgery establishment. Because the innovator has for enemies all those who have done well under the old conditions and lukewarm defenders in those who may do well under the new. And that was extremely true. The surgical establishment really thought that this was totally crazy and it would never, ever, ever work. And then Peter Drucker, he always has great quotes. But that still implies that change is like death and taxes. It should be postponed as long as possible, and no change would be vastly preferable. So Perotti actually submitted his seminal work. I actually had the privilege of being at his initial presentation at the SVS in 1991, where he presented 5 patients. It was an incredible experience. But he submitted his work to the Journal of Vascular Surgery, which is the journal for vascular surgeons. And it was rejected. It was a crazy idea, and one of the editors was actually visibly angry about the fact that he would even consider such an approach to the abdominal aorta. So he ended up publishing it in a fairly low-impact journal, Annals of Vascular Surgery, but it is one of the greatest papers in surgery in the 20th century, and has changed radically our approach to aortic pathology. So this is just, in a global way, this is an act of creative destruction. This is a really difficult book to read, but it really is, I think, for surgeons, a good book to know about, because you're, as surgical residents, and even those earlier in your career, you're going to go through significant surgical disruptions and creative destruction, where ways that you had done it in the past are going to be replaced as technology advances. And you're going to have to be willing to go with that, to learn from it. You're going to have enough discernment to not go out into tangents which hurt patients, but also to be able to see where certain developments actually can improve the care of patients. It's going to be very, very different in 30 years for all of you in the practice of surgery. You just think about it, the telephone, we got the iPhone, Android, the typewriter, Smith Corona. We're going to make the finest typewriters in the world. That's how we're going to compete against the word processors. Well, they didn't compete. They went out of business. And then the teller at the bank. There's still some tellers at the bank, but most of us use the ATM. And so this is what's happened to aortic surgery from 2000 to 2010, this steady, inexorable change from open repair to endovascular repair, to a point that in residency programs for vascular surgery, we are concerned that is anybody going to know how to actually directly address the aorta and repair pathology. And it's a real concern. Because I do think that's always going to be needed, but how often it's going to be needed, I'm not quite sure. Could be quite uncommon, as it's already uncommon now. So we went from Creech's beautifully illustrated repair to now the endo, infrarenal, standard EVAR. We now have fenestrated grafts to deal with the renal arteries. And now we have branch constructs, although this is somewhat limited by the FDA and availability. But in Europe, most of these constructs are readily available. And now we're approaching and moving towards the aortic valve, the aortic arch, and this is the branch graft, subclavian branch graft construct by Gore that is in trial currently, and I think probably will be approved, and will move the endovascular treatment even closer to a total arch replacement. So that kind of gets into the concept that we have now specialties that are now starting to interact together and interface because of the location of the pathology. The aortic arch has always kind of been the purview of the cardiac surgeons and even the descending thoracic aorta to some extent. Vascular surgery usually was dealt with below the diaphragm, maybe thoracoabdominal in some institutions. Certainly interventional cardiology used to take care of pretty much the coronaries, but now they're out in the periphery and take care of many other vascular beds. So at our own institution, we kind of recognize that we need to kind of start to get along and to work together as a team, given how things were evolving in treatment. And this is myself with Ray Matthews, our Chief of Cardiology, and Von Starnes, our Chief of Cardiac Surgery. And we've been able to put together a pretty good relationship which allows collaboration and communication and collegiality at USC. But you know, surgeons, when you have, you know, competing interests, everybody's an enemy, right? So you have to get beyond the concept that everybody is out to get your little piece of the pie, and you got to think about how you can work together productively and effectively. So we put together some principles of engagement because we have to now play in this aortic space in the same sandbox. So we have to recognize there are overlapping pathologies, and we have non-overlapping skill sets. I mean, what cardiac surgeons can do as far as putting patients on pump, those kinds of things are really important when you start to approach the aortic arch from an endovascular perspective. You need to have a bailout. Vascular surgeons have excellent wire skill sets, not quite as much better than the cardiac surgeons do. Frankly, they're not all that interested in developing their wire skills, at least at our own institution. But we complement each other because of those skill sets that need to be in the same operating room at the same time. And we like to we set up a multidisciplinary aortic conference to facilitate this collegiality, and we actually have a combined cardiac and vascular aortic call schedule, so that depending on the day, the cardiac surgeon may take it. If it's a ruptured abdominal aortic aneurysm, cardiac surgeon basically gets the vascular person on call to take the call and bring the patient in. Single common goal, best possible patient outcomes. So we need to all get along. And that also requires a collaborative spirit, some mutual respect. You need to build an efficient, reliable transport system for aortic emergencies, and you have to have mutual respect and trust to do that. And you have to have a highly functional aortic surgical team. So if we could pull this off, we'd eat like kings and things would really blossom, and in fact they have. We've had tremendous productivity in the academic realm as far as publications are concerned, looking at endovascular therapies, and we've established an aortic transport system which has been in existence since about 2012 with the combined aortic cardiac call, basically with the concept that if we get a call from an emergency room with an acute aortic emergency, that we will have that patient to our hospital within 2 hours, and then a care will be rendered. And this is our volume diagram, and as you can see, there's been this very progressive and steady growth in the number of acute aortic emergencies that we treat at Keck, getting close to 300 a year. This is from a paper that we wrote about our early experience. We had 183 acute aortic emergencies in this particular paper. You can see the breakdown of the pathology that we treated, and I'll just focus on the type B dissection and ruptured abdominal aortic aneurysm, and you can see that our overall mortality was 15%, but very, very respectable for those two particular pathologies that can be lethal if not effectively treated. So the concept of regionalization now of aortic care is a real concept and thought quite a bit about. Dr. Mell has written about it. and there's a great deal of interest in the vascular community. This is from Clem Darling's paper looking at his experience in Albany. Basically, the take-home message is that mortality is improved, but it's improved because transfer allows a greater application of the endovascular technology to treat these acute aortic emergencies. So if you are going to have one of these aortic centers, you need to have the skill set to treat just about any pathology that the thoracic or abdominal aorta presents to you, either in a semi-urgent, urgent, or elective fashion. You don't get to choose what the pathology and the problem is. You simply have to figure it out once the patient gets there, and you have to have the toolbox of therapies to be able to manage these patients. So this is the hybrid room, 1999. This is the hybrid room in 2019. It's become a very, very highly sophisticated operating room, angio suite, CT scanner, virtual reality, and this is, I think, the developments of this kind of technology is going to be the next leap forward in treating at least aortic disease. I think you're going to see more and more virtual reality type therapy application going forward. To be able to treat the wide variety of patients and pathologies, you've got to be able to be nimble and really position modified endografts is what is required. So you have to have somebody or some buddies at your center who have the skills and the ability to do a modification of endografts. It's not simple. It does take a lot of dedicated expertise and time to learn how to create these grafts and successfully deploy them. This is just an example of the physician-modified graft. These grafts are created on the back table prior to the operation starting. Usually takes about an hour to create the fenestrations and branches that one might need to perform treatment. This is our complex EVAR experience up to 2018. Hasn't been updated since then, but it's actually grown even further. Most of this work is Dr. Hahn, my junior partner, has created and built this program. Has just done an outstanding job. It's very labor intensive, as you might imagine, but very rewarding, and it allows us to treat any pathology of the aorta in an endovascular way. So he's currently placing an IDE investigational plan, working with the FDA. Part of it is to assess the safety and effectiveness of PMEG, but the other, I think, interesting aspect to this is to assess the degree of patient frailty before and after repair of abdominal aortic aneurysm. So I'm going to close talking a little bit about that because I think that's also another major challenge that we as vascular surgeons and surgeons in general have going forward with the technology and the things that are available. Because we do have elegant technology, it's minimally invasive, it's expensive, there are limited resources, and there's really ethical questions of care. And we somehow need to sort this out as a surgical community. One way of assessing frailty is to look at muscle mass, and specifically psoas muscle mass. And this is from a paper in the Journal of Vascular Surgery looking at thoracic sarcopenia and trying to predict morbidity and mortality for patients undergoing endovascular repair. There are similar papers looking at psoas muscle mass and frailty in patients undergoing endovascular repair. This is a patient of ours, 79-year-old, had a bilobed expanding abdominal aortic aneurysm, ejection fraction of 13%. Cardiologist cleared him for the procedure He was not sitting in a wheelchair in the office. He actually looked quite well in the office and absolutely wanted to get this aneurysm treated, and was willing to accept the potential risks. But you can see in measuring his psoas area muscle mass, it's about 1,000 millimeters squared. It's pretty atrophic. And if you look at this paper from the Journal of Vascular Surgery, looking at the potential for mortality based on psoas muscle mass, you see this nice curve. He's at 1,000, so his risks are significant. The story ends that he had the repair. The repair went beautifully. He's doing well. We're getting ready to discharge him, and then he had a gigantic MI and expired. So, in retrospect, should we have maybe not pushed this in that patient? We had a cardiology clearance, but unfortunately the cardiologist often will clear many, many patients that really are not surgically fit. So this is a problem that we need to address. This is another approach to measuring frailty that we're using at USC. It's a simple armband that you basically have the patient flex and extend for 20 seconds. And then it gives you this report and a frailty index based on their ability to flex and extend, how fast they do it, the velocity, the quickness, the number of times. It's been indexed, and you can determine with pretty good reliability whether the patient has some degree of frailty or not. This is actually from a peripheral arterial disease population, looking at both patients at Keck and at County Hospital. You can see the County Hospital patients are a little bit younger, and actually the Keck patients are more frail. But about 30% of patients in this patient population are very, very frail. So what do we do with these patients in trying to care for their vascular disease? We need to figure this out. I don't know that I don't have any answers yet, but I do think that this is something that needs to be looked at very seriously over the next couple of years. And this National Institutes of Health Care Excellence from the UK kind of brings this home. These are the NICE guidelines. This is a May 2018 draft. They haven't actually put these guidelines in place, but if you read these guidelines, it basically says do not offer EVAR to anybody. They either get open repair or they go out to pasture. And as far as complex EVAR is concerned, that isn't even considered. So this was met with, as you can imagine, the surgical community in the UK. It was met with a lot of skepticism and disgust. And in fact, the panel that put these guidelines together, there were no vascular surgeons on the panel. And there's a lot of very, very well-known vascular surgeons in the UK that would have loved to participate. And this was based on, even though it's couched in terms of care, it simply had to do with the economic necessities of the UK British healthcare system and their inability to actually fund and pay for endovascular care. Now, these guidelines haven't gone into force. They may not, because I think the pushback from the voters probably is going to prohibit this, but this is just kind of a shot across the bow, and don't think it can't happen in the United States of America. I think it very well could happen. So that it makes it even more important that we as surgeons start to figure this out, or we're going to have somebody else telling us who we treat and who we don't treat. So back to Albert Einstein. He actually went back to Princeton Hospital in 1955 with a ruptured abdominal aortic aneurysm. At the time, there was the ability to replace with a prosthetic graft. And so he was offered repair of his aneurysm in 1955. But it's a great quote. He declined. I want to go when I want. It is tasteless to prolong life artificially. I have done my share. It is time to go. I will do it elegantly. It's a little bit different perspective than what we sometimes experience in the clinic with our patients. But this guy, after all, was a person of the century. So, the evolution of aortic surgery, past, present, and future. In the antiquity of the 1950s, we couldn't fix it. It was a lethal disease. 1950s to 1990s, we finally could fix it, and we fixed it well, and we prolonged life. 1990s to 2019, now we can easily fix it. It's really not very difficult to fix an abdominal aortic aneurysm at this point, particularly a routine, straightforward EVAR. But today, really the question is, should it be fixed? And I think that's a question that we have to answer as a community. So I'll close again with a couple of quotes. One from Einstein: "The person who follows the crowd will usually go no further than the crowd. The person who walks alone is likely to find himself in places no one has ever seen before." He clearly exemplified that in what he did with his life. And then this one from George Bernard Shaw: "The reasonable man adapts himself to the world. The unreasonable one persists in trying to adapt the world to himself. Therefore, all progress depends on the unreasonable man and woman." So let's all be unreasonable in thinking about how we might move forward in the surgical treatment of aortic aneurysms. I really appreciate your attention and time, and it's been a great honor to be here. Thank you.
Well, I just want to give you this little reminder of your being here.
Thank you.
We have a lovely, you saw our
Oh,
DA sort of hanging out in the front. And I do also want to tell you that it is possible to get this on the plane. It is not considered a weapon.
They're not gonna abscond with it. Okay, good. Thank you.
Thank you so much for that fabulous
Thank you.
lecture, and really just an amazing walk through so many things, ethics, innovation, so much stuff that describes the great, rich life of being a surgeon.
Isn't that true? And every surgical specialty has the same story out there.
We have time for a few questions. Okay. Let's start with Dr. Pevick, our recently.
So we are in the process of further developing our aortic center. This is more pragmatic than a medical question. What is the process? How did USC go from having a handful of acute aortic transfers in 2012 to nearly 300 in 2019? What's the mechanism to get your hospital to play along, get all those patients in? What's the mechanism to get the word out, get the referrals directed to your center?
Yeah, so I think it's a multi-step process. First thing is you have to get your cardiac surgeons and your vascular surgeons in a room and agree upon some rules of engagement. What we ended up deciding was that every TVAR, anything that was endo in the chest, we would do together. And we would split, as far as the type B dissections, we would split the dissections. Every other one would go to vascular, that kind of thing. I had a lot of resistance from my own faculty about that. They were not happy, and they always thought the cardiac guys were kind of stealing cases and all that kind of thing. But the reality is, when we actually look at the numbers, it wasn't true. And so the first thing is establishing those kinds of rules, and then having the trust to actually proceed and work with each other. And we had to go through that whole process. But actually, the credit to particularly the young faculty in both cardiac and vascular, and I think Starnes and I have done a very, very good job of modeling that collaboration, and so they've adopted it. So that's number one. It's obviously key. The second thing is that, and I think it's a tougher one, is the hospital. You've got it. So what we set up is we set up a commitment. So Keck is a little bit different in a sense. We don't have an emergency room. So what we have is a thing called the Evaluation and Treatment Center. And so we made the Evaluation and Treatment Center kind of basically the the focus of receiving transfers. And then we got a 24-hour ambulance service on site. And then I actually ran the ETC at its beginning. And so I kind of pushed to get this, and we created a program where, you know, we get a call, we don't ask about, there's no financial clearance. We had to get the hospital to agree to that. There's no financial clearance. The other issue is beds. And so you have to work with nursing, and we've been, I think, successful finally getting nursing to understand, but that is a problem. But we finally got beyond that. And then you have to have the OR capability, and I think you guys are suited for that because you have a trauma program. So you have people here that, you know, are ready to go 24/7. But the hospital's got to come alongside, and I think you can take that slide and say, look, you know, if you build it, they will come. And then the next thing is to get out in the community, like, you know, put some flyers together, some nice marketing stuff, go to the emergency rooms, talk to the ER docs. We all know that the ER docs just want disposition for that patient. So once they know that you just pick up the phone and say yes, then they will be calling.
But you gotta be able to say yes, so you gotta keep.
You have to be able to say yes, and you can't, the financial clearance is you cannot, you know, ruptured aortic aneurysm, well, we got to find out, that doesn't work.
Just a follow-up on that. The hospital actually, within the last month, has agreed to accept all aortic transfers, so from the valve all the way down. So we've actually just very recently made a major, removed a major
Blockage.
block.
Yeah.
I'm sure there are more for us to do, but I do agree that, you know, that a lot of it is building it. They will come. When I was in the Bay Area, we would frequently get these calls, and these community hospitals would call in 4 or 5 hospitals, and whoever said yes first got the.
That's exactly what goes on in LA.
Got the patient, and so the potential is there. Can I just ask, what kind of infrastructure do you have right now within the department and within the hospital to support the aortic program?
So we do have a dedicated nurse practitioner that basically coordinates the calls during the day. So she carries the beeper, and when something comes in, she has a call schedule, and so she knows who to get in touch with to facilitate it at night. You know, who's ever on call's got that beeper. There is, you know, beyond that, a lot of the structure is basically what we already have. I think we need more structure, but right now, basically that nurse practitioner is the key component. I think you have to have at a minimum that. You've got to have somebody that can, particularly during the day when we're all in the operating room or doing other things, to carry that beeper and triage those calls so that you don't have a big time delay in trying to get in touch with the surgeon. And so she does that, takes care of that. We have, you know, they've provided money for marketing, those kinds of things, but HR, other human resources, I'd love to have a dedicated, you know, data analyst, database manager for us for this. I think we could be even more productive from a research standpoint if we had that, but you know, that's not happened yet.
We solved the problem here of the cardiac vascular at one level by recruiting Victor Rodriguez, who trained in both. So we thought he was the perfect bridge to sort of bridge that gap.
Yeah.
And he speaks both languages.
Oh, yeah, exactly.
That's work in progress. I wonder if you could comment a little bit on, I was told one time by a well-known vascular surgeon that I was a dinosaur because I fixed thoracic abdominal aneurysm open. What do you foresee in terms of the branched endograms? Am I really truly a dinosaur?
No, I don't think you're a dinosaur, but you'll probably be somebody who will be a lot less used than you were in the past. I think, you know, when you're talking about connective tissue diseases, unless there's something that happens that's going to be revolutionary, you're going to be doing those patients open and open thoracoabdominal repairs. I think where the endograph comes in is for the atherosclerotic aneurysm, non-connective tissue disease, right? Maybe dissection related. That's where the branched endografts are going to be used. And in our place, we try to figure out a way with every pathology except connective tissue disease to do it endo. Because most of those patients are, 50, 60, 70. Clearly, I don't see any value in doing thoracoabdominal aneurysm repairs open in patients that are 70 years of age. I've always thought it's crazy. It is crazy. And there's a lot of papers out there that say how wonderful these patients do and everything's. That's not been my experience, So I think that's where it is. But the set to do open surgery and do it well, connective tissue diseases, is that those patients are going to need it. I mean, that's when it comes to the aortic arch, I think it's going to be very interesting. But I think most of the arch stuff is going to go the same way that open thoracoabdominal repair has gone. Although the issue with the arch, which is a little bit different, is the stroke risk with endo repair is not small. Of course, the stroke risk with open repair is not small either. So.
Well, we look forward to having a little more time with you. I'm going to give the last word to Dr. Goodnight, and then do appreciate your willingness to stay around and talk with some of our faculty
You bet.
and residents.
Yeah, thank you, Diana. Thank you.
Jim? Fred, that was a wonderful talk. I was impressed with. This is a relatively short history. You think 1950 onward.
I know.
Dramatic.
Incredible.
You outlined very nicely the cooperation among specialties that must occur to make continued progress. One of the things that's very good is our payment system, the payment for individual procedures and so on and so forth. How have you made progress in that regard with this multidisciplinary center?
So we, I think this is where, depending on your practice plan and an academic medical center, you can kind of nuance this so everybody feels like they're getting their piece of the pie. So we haven't had issues with regards to that, and I think a lot of it is that the way that we're set up from a professional fee perspective, we don't necessarily totally eat what we kill. We basically have a salary. We have a small bonus pool, but the bonus pool is not such that people are going to, be going around stealing cases behind people's backs so that they can get, an extra whatever. So it's actually worked out. I have not heard from any of my faculty or any that I'm aware of in cardiac surgery that that there's an issue at all in this. It does become a little different with the cardiologists because the money is then outside of the Department of Surgery. We have a really good group of interventional guys that work very well with us, and we just haven't really paid attention to that. Per se, probably because we do the lion's share of the endo work in the place, so we don't feel too threatened about it. But I think that's a great point. I do think academic medical centers can actually help with that, right? I mean, there's a way. When you have out in the community, that basically balkanizes everything. So we have a unique opportunity as academic medical centers to create these programs, and then to bring these kinds of patients that require not just one specialty, multiple specialties here to do the work. And I think it's the best thing for the patient too.
Great. Thank you again.
Okay.
Thank you.